Hello, everybody. My name is Nick Pompa. I'm one of the neurologists at Southeast Veterinary Neurology. Hopefully you can both see and hear me. If you can't, please use the questions tab there to let us know. That way we can help you troubleshoot that. Ashley and Emily will be helping me kind of triage those questions along the way. So please feel free to reach out if you have any technical difficulties. So our topic today is going to be to review some of the common neurologic emergencies that you may face both in kind of private general practice as well as in emergency practices. A few quick things before we get started. I did want to let you know along the way, feel free to submit your questions. I do anticipate having plenty of time to review questions at the end. So along the way, as you have questions, just kind of use the format here within the application to submit those questions, and then we'll be monitoring them along the way, and at the end, we'll go through as many of them as we can. Any of those that I don't answer at the end, I'll contact you afterwards to provide an answer for you. Also, like I said, the technical questions can still be submitted there, and Ashley and Emily will help us troubleshoot that along the way. Other housekeeping items, your CE certificate for attending will be available to you about 1 hour after the presentation. It's going to come to you automatically through the email that you used to register, so you don't need to feel obligated to do anything or remind us. We're going to send it to you automatically, and you'll get it within 1 to 2 hours after the presentation is over. I did want to announce for those of you who are local here in South Florida that we've opened our third location in South Florida, which is in Jupiter, about 2 weeks or so ago. So for those of you in Palm Beach and the surrounding areas, in addition to our Miami and Boynton Beach offices, we now are glad to help your patients at our Jupiter location as well. Some of you may already know, but we do an annual Southeast Veterinary Neurology 7 Synapse Conference. It's a CE conference for veterinarians and veterinary technicians. We do it each October. This year it will be virtual, and there's a registration link here for you. It is case sensitive, but if you go to that website there, you'll be able to see what we've got planned for you this October. So it's right around the corner, so go ahead and get registered if you're interested. There's 5 CE hours offered through that program there. So now to get started, so again, our topic is kind of the approach to common neurologic emergencies. It is hard to talk about approaching neurologic emergencies without having some fundamental background as it relates to how to do a neurologic examination. So we'll spend about the first 15 minutes or so that we have together reviewing kind of the fundamentals of the neurologic examination. Kind of what are the main things that you need to focus on to do kind of an efficient, practical neurologic exam. Because without that, you won't really be able to approach the neurologic emergencies that we're going to talk about without kind of that fundamental information kind of going into your decision-making process. And then we'll touch on kind of 4 of the most common presentations of neurologic emergencies. So the first of which being, you know, the standard quote unquote down dog or non-ambulatory dog. So walking problems, if you will, whether that be paraparesis, paraplegia, etc. And we'll go through that in reasonably strong detail. Second one will be seizures and status epilepticus. That's always a frightening phenomenon for veterinarians when we have a patient that comes in, you know, actively having a seizure. So we'll talk about a calm, cool, and collected way to efficiently approach that patient's care and get them what they need, as well as the acute vestibular symptom presentation and head injuries and traumatic brain injuries. Obviously, that's not an exhaustive list, but I think kind of the approach that I'm going to walk you through for those types of, you know, those 4 most common emergencies, you'll be able to extrapolate from that for the odds and ends for the, you know, slightly less common things that we may not cover. And certainly if you have questions about other types of emergencies, use the program here to ask your question, and hopefully we'll be able to chat about it at the end. So kind of the goals of the approach to a neurologic emergency really do still need to start with the history. And you'll notice, you know, I've got probably 6 or 7 slides that, you know, start with, you know, the history and reminding us of the importance of the history. For a lot of neurologic problems, how we're going to prioritize our differentials and, you know, our plan. A lot of it is actually from the history. So just like your approach to other organ systems, when it comes to neuro, we can't panic and be like, oh my gosh, the dog can't walk. We need to take a step back and assess the history. It really does make a difference for many of these cases. A reminder of triaging the whole patient. So sometimes we got so focused in on whatever the neurodeficit might be that we don't spend quite enough time thinking about sort of the rest of the patient. And we need to be real cognizant of their overall systemic health and systemic stability, both because it has implications as it relates to the plan for that patient and the prognosis, but also it's going to have implications as it relates to your neurologic exam findings. So ideally, your neurologic exam is performed after some basic stabilization in an unpatient stable. Sort of a little bit crude of a quote, but someone once said it to me, and it's quite true, that every patient is neurologic before they die. So regardless of why that patient is near death, they're going to appear neurologically abnormal. And I know that sounds fundamental and quite crude, frankly. It's true. So we need to, interpret our neurologic exam in light of their overall systemic health. So the history, the physical exam, the triaging of the rest of the patient is quite imperative before we launch into the neurologic exam. The neurologic exam is going to lead us to our neurolocalization, meaning where do we think the problem is occurring within that patient, which helps us come up with a list of differentials. Those differentials obviously lead to a diagnostic plan, which is how we come up with the prognosis, the treatment plan, as well as kind of along the way, we'll chat about kind of when to refer these patients, realizing not every dog that needs to be referred is a candidate for referral from an owner perspective, but we'll talk about kind of best timelines for referral for some of these emergencies, as well as possible mistakes or at least sort of less optimal sort of interventions or delays of intervention that sometimes occur frequently that we can try to eliminate. Said a different way, kind of in a more picture format here, this really has to be a very systematic, stepwise approach, both for the neurologic exam itself, but the information leading up to the neurologic exam. So you need to have an accurate signalement, an accurate history, a thorough and accurate physical examination. Then we can perform our neurologic examination, which leads again to our localization, meaning where do we think the problem is located within that patient's nervous system. That will allow us to come up with a more exhaustive list of differential diagnoses, meaning we can go through vitamin D or DAMIT-V or whichever scheme you prefer to utilize to make that extensive list of degenerative, anomalous, metabolic, neoplastic, nutritional, infectious, inflammatory, toxic, traumatic, vascular. Make that long list. And then applying the signalment, the onset, the progression, you'll be able to narrow that very long list down to probably just a couple of things. Almost all neurologic patients, if you approach them in this fashion, you're going to take the 100 things it could be and probably narrow it down to 2 or 3 before performing any tests at all. And then that lets you take that prioritized differential list and come up with what's the most practical, streamlined approach to diagnostic testing for that patient. The neurologic exam itself, it's really got to be kind of an all or nothing thing, meaning we've got to do every step of the neurologic exam to get the most information out of it and the most accurate sort of assessment at the end of it. Remembering that the goals of the neurologic exam are to decide, does this patient have a neurologic problem at all? So is it neurologic versus maybe orthopedic or systemic? If it's neurologic, where do we think their problem is located? And we don't have to overcomplicate it. Do we think it's a brain problem? Do we think it's a spinal cord problem? Or do we think it's a neuromuscular problem? And we're going to go into that in more detail, of course. But if we don't look at kind of all 6 of these tenets of the neurologic exam, we're not going to be able to answer that question definitively. So we need to evaluate their mentation. What is their level of interaction and appropriateness as they navigate your exam room and as you question the owner as it relates to the history and what they're doing at home, or their cognitive and sort of mentation status changes. The gait, the posture, and we'll talk about each of these a little bit more. The cranial nerve assessment, the postural reactions, the spinal cord reflexes, and then nociception. And nociception is the only thing on this sort of list of things that we need to evaluate that does not always need to be evaluated. So Nociception is that evaluation of deep pain, and that's something that we only need to evaluate if they've lost motor function in the limb in question. So if they're moving their back legs, even if they're not walking, but they're voluntarily moving those limbs, then they can feel them, and you don't need to necessarily check for deep pain. When we start checking nociception or checking deep pain is when we don't have any voluntary motor function in the affected limbs. So for mentation and behavior, a lot of this is going to be historical information, because realizing in your exam room, you've only got a few minutes to evaluate that patient's sort of interactions, which you certainly need to do. But a lot of it is going to be asking the right questions of the owner. So often what I'll do, at least pre-COVID, when we were doing the exam in front of owners, I would let the dog walk around while I chat with the owner. So while I'm kind of recapping the history and asking the right questions, I'm also watching what the dog is doing. And we've all seen enough dogs, in the exam room to know kind of what's the average of what dogs are gonna do, who's just nervous but appropriate, and maybe who's not appropriate. So watch how they're moving around in the room. Obviously, at the same time, you're going to be evaluating their gait and their posture and other features, which we'll talk about in a second. But what's their level of appropriateness? Do they seem appropriate for, a dog in an exam room in a scary place? Asking the owner the right questions, like I said. So behavioral changes at home, circling, pacing, getting kind of caught in corners, self-isolation, loss of previously learned behaviors. All of those things would clue us in that, our mentation and or behavior are maybe not quite right. That by itself is not going to localize your patient, but it's an important piece of information as you apply the rest of your examination. When we try to describe mentation and behavior, it's relatively important that we are all speaking the same language. Kind of things like ADR and ain't quite right. Those things don't have a uniform meaning. So ideally, we're using phrases that have a formal definition, that we, when we say obtunded, we all know what we mean by that, and we can immediately cue up a mental image of what you're describing for that patient. So the 5 that I like are normal, depressed, obtunded, stuporous, or comatose. So normal is, they're acting like you would expect for, a normal dog. They're bright, alert, appropriately responsive to environmental, auditory, sensory, tactile stimuli. Depressed, they're still mental normally. They're not overtly mentally inappropriate, but they're maybe just quieter or subjectively, a bit lethargic for your taste or for the owner's taste, since they obviously know what the dog's normal energy level and activity level is like. Obtunded is where we've got a dull mentation. So there's a decreased consciousness and a decreased response to more mild stimuli. So real subtle things, aren't going to really kind of cue them up very much. They're going to keep their kind of far out and kind of dull mentation. Whereas a stuporous dog is obviously a progression worse than that, where they've truly got a decreased consciousness. They're not unconscious, but they've got a decreased consciousness such that they really only respond to noxious stimuli. So, real gentle tactile stimuli and auditory stimuli, a stuporous patient's not going to react in any way to that. But if you take a hemostat and apply, pressure to one of their digits for the sake of example, that's a noxious stimuli that hurts, and they'll be able to, rouse a bit to that response. Again, maybe not as normally as if you did that to a dog with a normal mentation, but you'll get some rise out of them. Whereas a truly comatose patient, no matter what you do, you're not going to get a rise out of them, so to speak. So they're truly unconscious. So you're not going to get them to respond even to the most noxious of stimuli. So kind of when you're evaluating how they're, moving about in the room or how they're appearing on your table, to decide about their mentation and behavior, see kind of which of these 5 categories makes the most sense. And then we're going to move on to evaluate the gait and posture. So when you're looking at posture, you want to evaluate kind of each of these a little bit differently. So take a moment and say, okay, what's the posture of the patient's head? What's the posture of their neck? And what's the posture of their spine? So cute little Chihuahua here has a very dramatic right-sided head tilt. So we name head tilts based on sort of which eye or ear, if you will, is lower to the ground. So he's tilted to his right side. Whereas our cat in the middle has cervical ventroflexion. And then our little dotson to the far right is markedly kyphotic. So he's got that dramatic arch in his mid-back. You'll also notice that he has low head carriage, and it's kind of doing that, what I call turtling appearance, where he's got his neck kind of down and in, is looking around with his eyes as opposed to moving his neck. And that would be a giveaway for cervical pain in that example. So evaluate both the head, the neck, and the spinal posture when you're thinking about posture. There are a few kind of relatively pathognomonic, at least as it relates to where the problem is located, postures. So a Schiff-Sherrington posture, such as the dog's seen on the left-hand side of the slide, that is suggestive of a T3-L3 spinal cord problem. So when you look at the posture of these three animals in these pictures, they might look somewhat similar, but they're distinctly different, and it suggests that the patient's problem is in a distinctly different location. So for the doggy on the left that has this quote-unquote Schiff-Sherrington posture, you wouldn't be able to tell from the photo, obviously, but his cranial nerves and mentation are normal. He's wide awake, he's appropriate. His front legs have an increased tone, whereas his pelvic limbs are flaccid. And then if you get that dog up and advance him forward, he moves the front legs relatively normally, except for that hypertonicity or that stiff nature. But he's got normal movement and normal proprioception in those thoracic limbs. And he has a flaccid paralysis, i.e. no voluntary motor in the pelvic limbs. That means that he has a T3-L3 lesion. Whereas the kitty in the middle has a decerebrate posture, and we're going to tell decerebrate from decerebellate pretty easily because of the difference in their level of consciousness. So the cat in the middle, obviously, again, I realize you can't tell from just a still photo, is unconscious. So the decerebrate cat is going to have a relatively similar posture as these other postures, but it's an unconscious patient. And that's by far and away going to be the most critical of these three postures, because that kitty is going to be at the greatest risk for imminent death without immediate intervention if possible. Whereas the decerebellate little Pomeranian on the right, he's actually quite conscious. So his limbs look very similar to our kitty, but he's very, very conscious. Oftentimes the decerebellate patients will have flexed pelvic limbs and extended thoracic limbs, but there are different versions of that that may not always be present. But these are distinctly different. But if you look at them just as they lay on the table here, they all look pretty similar. Once you dig into their exam, they're very different, and they mean very different things as to where the problem is located, and to a certain degree, the severity. When we look at gait, there's a few separate things that we want to look at sort of individually. So we want to evaluate for ataxia. So meaning, is there a lack of coordination of any of the limbs? So obviously this only applies if they're able to walk. If the patient's unable to walk, you won't be able to say if they're ataxic. They've kind of passed that step, because you can't be uncoordinated if you can't move your limbs sufficient to walk. So this is for patients that are up and walking. You want to determine if they're ataxic or seem like they don't have good awareness of where their limbs are in space or are otherwise uncoordinated. There are three different types of ataxia. So there's a vestibular ataxia, a cerebellar ataxia, and a proprioceptive ataxia. So vestibular ataxia is going to obviously be patients that are, the giveaway there is they're going to have other vestibular symptoms. They have a head tilt, a nystagmus, circling, things like that will help kind of clue you into what type of ataxia they have. Oftentimes, the cerebellar ataxia is going to have more of a hypermetric type gait, where they're kind of overflexing their limbs beyond what's necessary to get the job done. They may also have other cerebellar features, tremors, and sort of a titubation or a sway to their body, things like that. Whereas a proprioceptive ataxia is going to be kind of the run-of-the-mill spinal cord ataxia. So your dogs that have slipped discs but are still up and walking, they're going to likely have a proprioceptive type ataxia. Ataxia is not necessarily specific to any particular disease or any specific localization. So there's brain problems resulting in ataxias. There's spinal cord problems resulting in ataxias, which is of course the most common. And even to a certain degree, peripheral nerve problems can appear ataxic. You also want to evaluate for weakness. So paraparesis, meaning both back legs are weak, versus paraplegia, whereas both back legs have no voluntary motor function. Same options for tetra. You can have a tetraparesis, meaning you can move all 4 limbs, versus a tetraplegia, where there's no voluntary movement in those 4 limbs. Or a hemiparesis or hemiplegia, again, where it's one side as opposed to front or back. So you can have left thoracic and left pelvic that are weak. That would be a hemiparesis. Whereas if you had left thoracic and left pelvic that were plegic, then you'd have a hemiplegia. Same goes, of course, for the right side. You can also have a monoparesis, a little less common, and even a monoplegia, likewise less common. The most common one here is going to be para and tetra, but don't forget about hemi and mono. And that's true weakness, and that weakness is different than the loss of coordination, which is the ataxia, and you want to evaluate them differently, and kind of, as you watch the patient move, be making an assessment of both of those factors kind of independently. When we apply plegia to any of those terms, whether it's tetraplegic, paraplegic, monoplegic, that's sort of, an absolute term. So we're not mostly paraplegic. We are or we are not. So they either move those limbs, whatever the limb in question might be, or they don't. So it's an absolute term. If you're paraplegic, you have no motor function of both pelvic limbs, for the sake of example. If there's a bit of weakness, then you might say that they're markedly paraparetic, for example, suggesting that both of those legs move, but maybe not so much. Next, we need to evaluate the cranial nerves. There's many different approaches to a cranial nerve exam. You can make it as complicated as you want to. The reality is it doesn't need to be complicated. So, particularly, we have obviously a mixed audience, but most of our audience is going to be primary care veterinarians or emergency veterinarians. And so you've only got so much time. So you need to get all of the information that you need, but you need to get to it efficiently. And there's lots of different mnemonics and little charts to help you remember kind of the order of the cranial nerves and which ways to assess them. And I'll show you an example on the next slide. But big picture, you'll probably get 90% of the information that you need by just looking at their face. So, cranial nerves are largely, bilateral. There's one for each side. So you kind of have a internal control where you can evaluate kind of one side as it relates to the other and use kind of that control for comparison. Obviously, you can have deficits that are bilaterally symmetric, in which case, you won't see that disparity. But for the most part, evaluate their facial symmetry and then go through the cranial nerves in a systematic fashion. If you always do it the same way, you won't have to really think hard about, gosh, did I forget one? Did I skip one? Find a 2 or 3 minute cranial nerve exam kind of flow that works for you. And if you always do it the same way, you won't have to think about it very hard. And then again, always remember to compare, if you're looking at one side and you can't decide about the pupil shape or size, or whether there's a little bit of a facial weakness or a little bit of reduction in muscle mass on one side, compare it to the other, and a lot of times it will help you see even the subtlest of disparities. Lots of different charts to help you go through this, and obviously I don't want to spend too much time on the neurologic exam since we've done other lectures and things that where we spend the whole hour on that, and we can certainly offer those more if there's interest. But I just want to kind of go through a quick refresher here so we can move into our more specific examples. But lots of little charts like this to help you get started if you don't already have kind of a schedule that works for you, as far as kind of how you like to go through the cranial nerve exam. So charts like these are nice to have around, so you can just remember kind of which nerves, innervate which structures and which assessments you can use on your exam to determine if there's a cranial nerve deficit. Next, and very, very important, is proprioception. So proprioception is our sort of conscious awareness of where our limbs are in space. So right now, while you're watching this presentation, if you flip your foot over onto the sort of top of your foot, you don't have to look down to know that your foot is not in its normal orientation, and proprioception, or that spatial awareness of our limbs, is what lets us know that. And in many of our neurologic patients, that's one of the things that can be lost sometimes quite early in the process. So we've got to check this to help us determine which limbs are affected, which is going to help us with localizing that patient. At a minimum, you want to do proprioceptive positioning, which I often just call paw replacement. There are many other tests of proprioception, but at a minimum, you want to flip over those little feet, and you want to see both the initiation and the follow through being brisk and complete and repeatable. So you do it a couple of times to make sure they do it about the same way every time. Obviously, if this dog left that paw turned over on its dorsum for a period of time before it replaced or indefinitely, obviously that would be, a proprioceptive deficit in that limb. Important, if you'll notice in this video, we're supporting the patient so that they're not going to fall during it. You just kind of support their weight to stabilize them and flip over one paw at a time. There's definitely many other tests of proprioception that you might sometimes need to evoke into your exam, but at a minimum, flip over all 4 of those feet in a systematic fashion. As it relates to spinal cord reflexes, in the thoracic limb, the most important reflex is the flexor withdrawal. That's a pretty integrated reflex that utilizes a lot of the nerves of the brachial plexus, so those nerves that come off between the C6 and T2 spinal cord segments. So pinch their toe, you're looking for that withdrawal of the limb up towards the body with flexion both at the elbow, the carpus, and the shoulder. So you want to see kind of all of those joints retract up. In the pelvic limb, the 2 most important reflexes to check are the patellar reflex, which is largely a test of the femoral nerve and its distribution, which is kind of the L4, 5, and 6 spinal cord segments, and the flexor withdrawal reflex, which is largely sciatic mediated. So you're looking mostly at the sciatic distribution, which is the L6, L7, and S1 spinal cord segments. For those reflexes, you want to obviously do them enough that you're comfortable interpreting the results. And so, patellar reflex is obviously quite easy. The main thing is you want the patient to be somewhat relaxed. And so you can see in this video, the dog wants to kind of pull his knee up and whatnot. And so you got to kind of get him relaxed, get it in a pretty neutral position. I will often do these standing. A lot of times the dogs get more tense when you lay them down. But this video shows kind of the right pelvic limb. The patellar reflex is normal, whereas the left is not normal. And I'll play that one more time. I realize it's a bit brief. So the up leg here, the response is pretty blunted, once the dog kind of relaxes enough to cooperate. Whereas the lower leg, the right pelvic limb down on the ground there, you see a pretty brisk extension with that nice snapping back. That's beautiful. That's exactly what you want to see. For the flexor withdrawal, likewise, you're pinching the toe and you're looking for that flexion of the limb up towards the body, just like in the thoracic limb. And that can also be done standing. These videos are illustrating the dogs laying down, realizing that oftentimes our patients get distressed when we lay them down, or the owners get distressed when we try to lay them down. So practice both ways to find what works for you, but I'll often actually do these standing. And then palpation is obviously a key part of the exam. So we need to know both whether our patients are painful anywhere and also whether there's a change in the amount of muscling in any of their limbs or any part of their paraspinal muscles or their muscles of mastication. So you really legitimately want to palpate them from their head to tail. Often I'll start kind of on the opposite end of where I think they're painful. So this is something you're doing towards the end of your exam in case you upset them by touching where they're painful. It's not going to make them, less participatory for the rest of your exam. So, start opposite. If you think they got neck pain, then I would start with their tail. If you think they've got, lower back pain, then I would start with their head. But nonetheless, you want to truly make your way from one end to the other, feeling both the muscle mass, feeling for fasciculations, feeling for discomfort when you apply gentle pressure, etc. And then lastly, you want to check nociception if there is a limb that does not have voluntary motor function, or a set of limbs that does not have voluntary motor function. So if you've got a Dachshund who's presented to you for being non-ambulatory and you've gotten this far in your exam, and no matter how much you tried to engage the dog, it moved forward with its front legs, but its back legs just dragged behind it without any clear voluntary motor function, then you need to evaluate nociception. Often that's very important for us in determining both the urgency of care and the prognosis associated with care. So it's a very important step. If we take one thing from this presentation, it should be this slide. So if you're multitasking, pay attention for this slide for me. It is very, very important that when we're checking nociception, that we're not confusing it with the flexor withdrawal. So you can have a dog that's quote unquote deep pain negative or nociception absent, meaning they don't consciously feel even painful stimuli coming from the affected limbs, but they can still have a flexor withdrawal. So when you apply this noxious stimulus, starting initially maybe with just your fingernail, and then if you don't get the response, you can obviously try a hemostat or something that provides even a stronger noxious stimuli. Just because you apply the stimulus and they retract that leg back does not mean that they have deep pain. We can transect their spinal cord in the T3L3 region and still have that reflex. That's a local reflex relative to C6T2 if we're talking about a thoracic limb, or L4S3 if we're talking about a pelvic limb, but it does not suggest that they have nociception. So whether they withdraw or don't withdraw is neither here nor there as it relates to checking of nociception. The reflex and the ability to feel are not the same. So if you pinch the toe and they pull it back, doesn't mean they feel. Likewise, if they don't feel it back, still doesn't mean they feel or don't feel. You're looking for a conscious response. You provide that stimulus, the patient swings its head back, tries to bite you, does something to tell you that that information made it all the way from the tip of the toe that you're pinching up those peripheral nerves through their spinal cord and up to their brain where they can say, ouch, that hurts. And so that's a very, very important distinction. And there's a lot of common sort of mistakes there in interpretation of that. So please ask if there's questions. We can talk about it more at the end because it's probably the most important thing in this presentation. So again, for the neurologic exam, you want to make sure you look at all 6 of those tenets, and then you need to start putting that information together. So the good news is the exam is multiple choice, right? So we all liked multiple choice better in vet school. It's nice. You don't have to make up choices. You've got fixed choices. Is it a spinal cord problem? Is it a brain problem? Or is it a neuromuscular problem? If it's a spinal cord problem, even better if you can say if it's a neck problem versus a back problem. So C1 to C5 and C6T2 are collectively neck problems, whereas T3L3, L4S3 are collectively back problems. Spinal cord problems, of course. Intracranial, if you can narrow it down beyond in the brain, great. If you can't, for the sake of most of your initial intervention, probably not going to change anything. As neurologists, we have to parse all of that out, but for those of you that are not neurologists, and are either primary care or emergency vets triaging, if you get into it's a brain problem, you're ahead of the curve already. So don't feel like you need to kind of narrow it down to exactly which tracks and which nuclei. Big picture for your initial intervention, if you can say it's a neck problem, it's a back problem, it's a brain problem, you're doing pretty well. Likewise, there are some classic neuromuscular conditions that would be wise to be able to recognize and differentiate from spinal cord problems. Ideally, you want to kind of take all of the abnormalities that you find on your exam and put them together into one location within the nervous system. So, you don't want to kind of say, well, that could be from the back and that could be from the brain and that could be from the nerves. See if there's one part of the nervous system that you can put all of those deficits, you can explain all of those deficits rather from one part of the nervous system. If so, that's probably where your problem is. Of course, it could be that it's multifocal and they're all coming from different places, but most of the time, if you've got 2 or 3 deficits, you can find in your mind kind of which part of the nervous system could account for all 3 of those things, and chances are that's where the dog's problem is going to be located. If it's a spinal cord problem, realize their mentation and cranial nerves would largely be expected to be normal. If they're ataxic, again, it would be a proprioceptive ataxia. If it's a cervical problem, C1, C5, or C6, T2, obviously all 4 legs are going to be affected. Whereas if it's a T3L3 or L4S3 problem, only the pelvic limbs would be expected to be affected. How you'll make the distinction between C1, C5, and C6, T2, and likewise the distinction between T3L3 and L4S3 is based on the presence or absence of the reflexes. So if it's C6, T2, you would expect the reflexes in the thoracic limbs to potentially be decreased or even absent, depending on the severity. Whereas in the pelvic limbs, in that instance, the local reflexes to the pelvic limbs would remain normal. Likewise, if it's an L4-S3 problem, of course, everything about the front legs, including the reflexes, would be normal, and you would have reflex deficits potentially in sort of dogs that are L4-S3, whereas you would not necessarily expect those reflex deficits if it were T3, L3. There's always some exceptions there. So again, if you get to it's a neck problem or it's a back problem, you're doing well. Neuromuscular dogs can be tricky. They can mimic, other things. They can be tricky to differentiate from spinal cord problems. For a lot of neuromuscular conditions, they would be expected to have decreased to absent reflexes in all 4 limbs. Not always, but typically. You might ask owners questions about changes in their voice, changes in their exercise tolerance, things like that. Some of the most common ones are tic paralysis, polyradiculoneuritis, which is sometimes called coonhound paralysis, botulism, and myasthenia gravis. The important thing about myasthenia gravis, as it relates to these other common neuromuscular conditions, is most myasthenic patients will have normal reflexes. So it won't be a dead giveaway that they're neuromuscular because their reflexes are often going to be normal, unless they're a fulminant myasthenic. But if they're that fulminant, they're likely having difficulties breathing and other things that are, of great consequence. But for the run-of-the-mill myasthenic, they'll have normal reflexes, even though they're neuromuscular. If it's an intracranial problem, you're going to expect either in the history or on your examination to have abnormal behavior or mentation. Often, ask questions about circling, pacing around, kind of changes in their sleep-wake patterns, etc. Oftentimes they'll have a cranial nerve abnormality, not always. The menace response is one of the most kind of reliable. It's a pretty kind of integrated sort of response that uses has to coordinate kind of multiple parts of the forebrain and the hindbrain. So that's definitely one of the most important cranial nerves to evaluate. Obviously, if they have a seizure, that can help you narrow it down as well. Although obviously for seizures, we have to consider both intracranial, extracranial, and idiopathic causes. Some common mistakes as it relates to the neurologic exam as we kind of wrap up this section. So obviously not performing an exam would be a mistake. So just because the owner says, oh my gosh, my dog can't move its back legs, before we panic, before we take x-rays, before we do anything else, let's stop and get that examination. Likewise, if the owner says, hey doc, my dog can't walk, and you look at it up on the table and check some CPs and things and they're not present, well, it doesn't actually mean the patient can't walk, right? So we've got to get them down on the ground and see what they can truly do. Also, it'll give you a chance to see if they're circling or doing other things that maybe the owner would not have mentioned. So even if you need to, use a sling, get an assistant, get them up, see what all of their limbs are doing. Just because they maybe can't walk as per the owner doesn't mean that they don't have movement, so we need to evaluate that. And then number 1 would be misinterpreting the reflex withdrawal for deep pain perception and vice versa. The other is starting diagnostics or administering medications prior to performing the exam. So if you don't do your exam before you give them, pain meds or sedatives, well, you might lose your ability to get an accurate examination, at least temporarily. So now moving on to kind of the 4 different common presentations to kind of have some tidbits about these kind of top 4. Obviously, you needed that foundation of a good neurologic exam before you could apply it to these scenarios. But the first of which, and presumably the most common out in general practice and emergency room practice, is going to be the non-ambulatory dog, the quote-unquote down dog, if you will. And so important things here, obviously the history, the physical examination that's going to come up for each of these, because to belabor the point, those things are critically important. And then for the non-ambulatory patient, localization. So where do you think their problem is? So even if it's obvious that it's a spinal cord problem, do you think it's a neck problem or a back problem? Is it C1, C5, C6, T2, T3, L3, or L4, S3? We need to know this because as you kind of hone in on your diagnostics, you need to know, where you're performing your diagnostics at. The next most important thing to know for these patients is how severely affected are they? So there's lots of different grading schemes. There's not a uniform right or wrong way to grade these patients, but typically we like to use this very simple 1 to 5 grading chart. It's easy to explain to owners. and it kind of has a relatively uniform, kind of definition, so we can all understand what we mean when we say a patient is grade 4 out of 5. So kind of it's a 1 to 5 scheme where 1 is the most minimally affected, meaning they've got potentially some discomfort, but no neurologic deficits. They're not ataxic, they're not paretic. They are totally normal other than they've got some discomfort, whereas grade 2 is a dog that is still able to walk, but they have weakness, whether that's paraparesis or tetraparesis, depending on where their problem is, but nonetheless, they're walking, but have a weakness. Whereas grade 3, they still move their limbs, but not effectively enough to walk. So they're non-ambulatory paraparetic, meaning if you support them, you'll see that all 4 legs move, but without support, they're unable to get up and take 10 steps without assistance. Whereas grade 4 are the dogs that are plegic, so obviously paraplegic or tetraplegic, but nonetheless, you're saying there's no voluntary motor movement in the affected limbs. And then grade 5 is, of course, the most severely affected, whereas there's no movement and also no feeling of the affected limbs. So they're most commonly paraplegic with absent deep pain or absent nociception. And that's, of course, the most severe category, grade 5. This recommendation as far as how we proceed here that this chart provides, obviously, a lot of things factor into this. It's not quite as black and white as the chart would say, but generally the take home here would be any dog that's non-ambulatory should have aggressive and immediate intervention to provide the best outcome. So if they cannot walk, they need to, ideally, assuming the owner is able, be referred immediately for emergency intervention. Whereas grade 1 and 2, there may be more of the potential for trying conservative management, depending on how rapidly they're progressing, whether it's been recurrent, what the owner's willingnesses and abilities are. But certainly the take home here would be that it's not quite as black and white as the chart would provide, with the exception of if they are non-ambulatory, they need immediate and emergency intervention that same day. And then obviously applying your differentials. So, whether you use vitamin D, DAMIT, V, there's lots of differentials. I've obviously kind of narrowed down the top 4 here for you, but this is not an exhaustive list. Obviously, intervertebral disc disease is by far and away the most common cause of acute paralysis in dogs. Things like a fibrocartilaginous emboli are also pretty common. Trauma, if there's a history of such, tumors. Obviously, this is not an exhaustive list. We have to consider inflammatory diseases as well, and a long list of others, but narrowing down to kind of what are the big 4 you should think of off the top of your head, when you approach the non-ambulatory patient. These 4 will certainly get you started, but realize it's not an exhaustive list. Diagnostic testing. So screening radiographs are often performed in general practice, and certainly it's a reasonable screening test for less affected patients. Your more affected patients should strongly consider referral for MRI. And if they're going to come for an MRI, I'm okay if we pass on the spinal radiographs because we'll get much more information out of the MRI. If it is a trauma case, though, taking radiographs is strongly recommended prior to transport so that we can identify if there's an obvious unstable fracture or luxation, so that proper handling recommendations can be made for transportation. Without question, across the board, spinal MRI is clearly the test of choice for non-ambulatory patients. It's going to have the highest sensitivity and highest specificity for spinal diagnoses and spinal diseases, and it has less risk than a CT myelogram. So not only does it have a higher diagnostic yield, it does have a little more potential for prognostic information to be gathered, but it also has less risk of neurologic decline. CT scans can certainly diagnose some spinal conditions. The challenge is, what if the things it can diagnose are not what's wrong with your patient? We've now done an expensive test without finding the answer, so an MRI is across the board going to be the preferred test. Additionally, CT myelograms, because of the introduction of the contrast agent, do run a pretty significant risk of resulting in neurologic decline, even if temporary nonetheless. It does have a potential to make the patient worse and is strongly ill-advised for the majority of spinal cases. As far as spinal radiographs, if you choose to take those as a frontline kind of screening test in your practice, they need to look like these here. So kind of we want to have the patient positioned very well. It needs to be a collimated radiograph with obviously, proper technique in order to get anything useful out of them. Obviously realizing you're not going to conclusively diagnose intervertebral disc disease, soft tissue spinal tumors, myelitis, FCEs, those things you're not going to diagnose here. However, it helps you ensure that there's not a maybe large osseous bony tumor, things like discospondylitis, fractures and subluxations will sometimes show on radiographs. So those would be more the things you'd be screening for with this type of test. If your spinal radiographs look like this, the odds of them being diagnostic are very, very low. So they need to be collimated. They need to be centered over the spine. The spine needs to be in a very neutral position. And we need to make sure that, we're looking at the area of interest. So, that's where the localization becomes so important. If your patient has a T3L3 problem and you take a radiograph that's from, L1 to the sacrum, even if it's a beautifully collimated radiograph, you're not going to find the problem because the problem's a bit upstream. So we've got to make sure that we're imaging the area of interest if we choose to do spinal radiographs. The conservative therapy options for these patients. So obviously, if you're doing conservative therapy for non-ambulatory dog in general and emergency practice, you're doing that, of course, without a definitive diagnosis, because presumably, you wouldn't have access to MRI. So the cage resting is the absolute most important recommendation. I can't emphasize that enough. So these patients need to be strictly crate confined because at this point you don't know that they don't have a disc. And if they have a compressive lesion like a disc, they must be rested in order to recover. Typically at least 4 weeks of absolute strict crate confinement. And that's more important than anything else that you're going to prescribe for these patients. Obviously, if they're painful, pain medications are definitely indicated. I've got some example options here with some common doses listed for you. And then there's the age-old debate about do we give them steroids, NSAIDs, or neither. Generally, my preference is if they're severely affected, meaning non-ambulatory, a low-dose oral tapering course of prednisone could be considered, depending upon their overall health and any other systemic contraindications. High doses of methylpred and Dex-SP are, for the most part, fallen out of favor. There's no legitimate science to continue to support their use, and we certainly know that there's great risks of such. So my preference here would not be NSAIDs. It would also not be high-dose steroids, but there is definitely, room and consideration for a low-dose oral tapering course of prednisone. This, of course, assumes you're not referring them. If you're referring them, we're going to want to see them immediately, and therefore you don't need to prescribe anything because we're going to want them to come over, right away. So just organize that with us. But if you're managing them conservatively without referral, then there's certainly consideration for such if they're non-ambulatory. A reminder that a lot of the high-dose methylpred sodium succinate studies were human studies from the National Acute Spinal Cord Injury Institute studies, which were overall largely refuted the sort of statistics and how they got to the assumption of that those medications at high doses might be helpful have long since been refuted. There's no concrete evidence that high doses of steroids are helpful. And then North Carolina State published this paper 4 or 5 years ago that sort of looked at polyethylene glycol and methylpred, both of which were thought to have kind of the potential for neuroprotection through radical sort of free radical oxidation sort of efforts. And there was no difference between the dogs who got the placebo, the polyethylene glycol, or the high doses of steroids. So it made no difference in this study, which is not surprising. So when to refer these dogs, assuming the owner, of course, is willing, these dogs should be referred immediately if they're non-ambulatory. So this is time-sensitive stuff. So we would certainly, if you're local to us, we would want you to contact us immediately so we can help you get that case referred over to us, without delay. What not to do? Obviously, these are opinions, but in my opinion, don't wait to see if they improve. If they are non-ambulatory, it's an emergency. Other things to not do would be to not give high doses of steroids, and don't wait and see what they look like tomorrow. There's a common notion of let's give him some Dex-SP and see what he looks like tomorrow. The problem is If tomorrow he's deep pain negative, his prognosis is now much reduced from what it was previously. So let's not take that chance unless, of course, the owner provides no other options for us, because time generally is going to equal function here. Next small subject is cluster seizures and status epilepticus. So cluster seizures are when we have more than one seizure in a 24-hour period. Status epilepticus is sort of continuous seizure activity as defined by greater than 5 minutes, or a failure to recover between subsequent seizures. In general, seizures we think about intracranial, meaning brain problems, extracranial, meaning organ problems, or of course idiopathic. The emergency intervention for these patients, we need, obviously, if they're actively seizing upon presentation, IV access and administration of a benzodiazepine is going to be the treatment of choice, and certainly step one. Got some doses here for you for diazepam and midazolam. Repeat those as needed up to 3 times until you have cessation of seizure activity. And then obviously, once the seizure is stopped, you can do your physical examination, particularly as it relates to checking their body temperature, because hyperthermia is certainly a risk here with prolonged seizure activity. And then obviously launching into blood work, baseline blood work and urinalysis, considerations for evaluating both the calcium and glucose, if there's any consideration for hepatic involvement, bile acids of pneumonia. If the patient's on phenobarbital or potassium bromide, evaluating where their drug levels are will also be a good thing to get submitted right away. What if the seizures don't stop? Repeat your benzodiazepine for up to 3 doses. If we're not getting the answer we need there or the response we need there, IV Keppra at sort of a loading dose of 60 mg per kg IV is certainly a consideration. Excuse me. Alternatively, phenobarbital in 4 mg per kg boluses could be considered. Only word of caution for phenobarbital is it's a little bit of a longer acting medication, so don't expect an immediate response to that bolus of phenobarbital. So some folks will give a dose and not see a response in 30 seconds and give another dose and do that over and over. Be careful, because once it does catch up with them, they may be, quite out of it, and we might run the risk of an overdose. So if we're using phenobarbital, we need to certainly give it some time to work. As a very last resort, if you can't get the seizures to stop with kind of versions of multiple doses of benzodiazepines, Keppra and phenobarbital, certainly propofol is an absolute last resort. We should aim to never have to do this, but in the sort of last, worst case scenario situations, it does have a time and a place, but it's far and few between. Don't forget about the need for, intubation, critical monitoring, etc. Generally, we want these patients to be on a concurrent midazolam CRI, because there's a reasonable risk that the propofol is kind of reducing the outward symptoms of the seizure, but if we had an EEG on that patient to actually look at their brain waves, we may not be sort of actually resetting those brain waves the way that we sort of intend to. So concurrently giving a midazolam CRI is going to be a wise choice. And then obviously, unless we think it's a toxin or something that's going to be, very quickly fleeting, you probably want to load your maintenance anti-epileptic drug while they're anesthetized and before they come off of that CRI, so that when you do start weaning off of this, they've got some type of maintenance seizure medication on board, so they don't go right back into seizures. Likewise for cluster seizures, both for in-hospital and at-home management, having a toolkit for these clients such that when the patient, if they're a patient that's known to have cluster seizures, when they have one, if they're known to have 2, 3, 4 seizures in the same day, we need to give them a toolkit after that first seizure to try to decrease the odds of that second, third, fourth seizure, which obviously would then necessitate hospitalization. So having a toolkit where they can give intranasal midazolam at home if they're of course comfortable, using some caution because we're near the mouth parts and a dog that's not going to be mentally appropriate. Also using clorazepate, a slightly longer acting benzodiazepine, for 3 days or so can help kind of break that cluster cycle. Also, I'll often use Keppra as a pulse therapy, kind of giving an extra dose of that. That combination of midazolam, clorazepate, and Keppra is often quite common. And of course, keep them on their maintenance medications during that period as well. One thing to recognize, and this is important both for head trauma and for seizure patients, is that Cushing's reflex. So as there's an increase in the intracranial mass volume, whether that's swelling, tumor, doesn't matter, there's a great sort of potential for the brain to compensate And as that sort of intracranial mass expands volume-wise, the actual intracranial pressure doesn't increase until it gets to a really critical point, and then it shoots up exponentially. And that's where we have to be able to recognize the evidence of increased intracranial pressure and intervene immediately. Otherwise, that patient is going to pass. With the Cushing's reflex, which is something clinically that you want to be able to recognize, the net result of this sort of phenomenon is hypertension and bradycardia. So often they're going to become more obtunded if they weren't already. You'll notice that they're hypertensive, but their heart rate is going down. If you notice those things in conjunction, we need to be really, really worried about their intracranial pressure. As such, we need to manage it. So obviously ensuring adequate ventilation, making sure we're not occluding their jugulars, keeping their head elevated 28 to 30 degrees is thought to be sort of the sweet spot to compromise between venous return and cranial blood flow. We of course want to maintain normotension. If they're hypotensive, it's going to worsen their cerebral perfusion pressure. And then obviously instituting drug therapy for increased intracranial pressure. Hypertonic saline and mannitol are, of course, the two most common drugs for that purpose. Everyone has a preference. There's not a clear cut which one is better. In traumatic brain injuries and in dogs who need vascular expansion, so dogs that are otherwise not euhydrated, hypertonic may have a place and may be preferred. Whereas mannitol, I tend to be using that in patients that have a normal vascular volume and the cause of their increased intracranial pressure is not a traumatic brain injury. But those are not hard and fast rules, and certainly if one doesn't get the response I want, I will sometimes try the other. So there's not necessarily a clear-cut choice. For seizures, kind of obviously differentials, there's an exhaustive list. The real distilled down version is, if it's a young dog, we're thinking mostly congenital and infectious causes. If it's an adult dog, we're thinking inflammatory, neoplastic, etc. If it's an older dog, neoplastic and vascular are going to be the top two. And you want to refer those patients as soon as they're stable. Now we've got vestibular. These last two will be much shorter. Don't worry, I know we're short on time. For the vestibular patients, again, the history of the physical exam. On your exam, you might notice, some combination. It doesn't have to be all of these features, but things like nystagmus, head tilts, circling, vestibular ataxias. Baseline testing that you can do, on the front lines, general health screening. So a lot of these dogs have an underlying general health problem. So like for most of the other issues, blood work, but also here in particular, blood pressure, thyroid testing, etc. The gold standard for diagnosing is, of course, going to be MRI. Lets us see both the inner ear, middle ear, if we're thinking that it might be more of a peripheral case, and obviously the brain all in one study for the more central cases. The empiric sort of supportive things that are acceptable for all vestibular patients are, of course, nursing care, fluid support, nutritional support, antiemetics. Anti-vertigo medications, meclizine, there's some debate about how well it works. I do think that for at least some patients, there is a benefit. I've never had a patient have an adverse event to it associated with it, so I don't think there's any reason not to try. Also borrowed from human medicine, they use diazepam as an anti-vertiginous medication pretty commonly. I do that as well, and very often it can be very, very helpful. If the owner is not going to pursue definitive diagnostics, you may have considerations for antibiotics if it's a dog that has sort of an increased risk factor for deep ear infections and things like that. If you think that might be the case, considering some empiric antibiotic therapy is certainly an option if diagnostic testing is not wished to be pursued. There may also be some consideration for steroids for those patients that are not getting better with time and supportive care. Certainly should not be a first-line consideration, and certainly should not be administered if you intend to refer that patient. Likewise, refer these as soon as they're stable, particularly if you feel central is more likely the cause, or if the symptoms are recurrent or failing to resolve with supportive care. Be careful not to confuse vestibular symptoms with seizures. Also, don't forget to evaluate their systemic health. Many of these patients have strokes and other sort of metabolic underlying causes that resulted in their vestibular symptoms, so make sure to evaluate their overall systemic health, and don't give them steroids if you plan to refer them. Lastly, and this one will be quite quick, don't worry, is traumatic brain injury. A lot of the stuff we talked about sort of as it relates to intracranial pressure, and the supportive care for that is an overlap here. Main thing here to remember is that most patients are unlikely to have a traumatic brain injury without injuring other parts of their body. So we see a high incidence of concurrent cervical injuries, but also, with major injuries, we need to think about heart and lung contusions, ruptured urinary bladders, internal bleeding, things like that, pneumothorax, the list goes on. So make sure we're evaluating their systemic health, because that is going to be equally important to saving them as managing their brain. There's a number of different mechanisms of injury in head trauma. There's certainly more than the two that I've listed here, but the two that are most clinical for the sake of management, contusive injuries, meaning concussions, are largely going to be treated with time and support, and most of them are going to get better. Whereas compressive injuries, things like depressed skull fractures or internal hemorrhage that's resulted in compression, and of course you won't see that from the outside, those things can require emergency surgery to maximize sort of as much function as we can save of their little brain. And you may not know that, from the outside, so keep that in mind. Evaluate their overall health, radiographs to look for other injuries, so chest, abdominal, full spine, all should be evaluated in addition to a consideration for skull radiographs. If the dog has neurologic deficits and the intention is to refer them for imaging, I'm okay if you skip the skull radiographs, because we'll get that information along with the rest of the information through the advanced imaging. Supportive care, a lot of this is similar to the seizure dogs that we talked about. Kind of two differences are, if you're managing these, think about antibiotics, because many craniofacial fractures end up resulting in a communication between the nose and the calvarium, and so we can have the potential for getting an infectious meningitis. So I'll put many of these on antibiotics even if there's not an open wound. Also, don't forget about pain medications. Even if they're obtunded and aren't able to necessarily show you how painful they are, they may still be painful, and pain is going to result in an increase in their intracranial pressure. So we need to be cognizant of that and managing that concurrently. And you want to refer these as soon as they're systemically stable, and you don't want to give them steroids. Steroids are contraindicated in all forms of head trauma in a very absolute fashion. And don't forget to manage and evaluate their systemic health and making sure that they're stable enough for transport and that we know what all of their other concurrent injuries are other than their primary brain injury. In conclusion, the most important thing is to approach these cases in a calm yet efficient manner. So, we need to have a systematic kind of stepwise approach to how we do the exam and how we recognize the critical time points for intervention. Most neurologic problems, time equals function. We've got to get these patients the best possible care as soon as possible. So making sure that we don't underreact, as it were. We need to take the time to do the exam and do, our systemic approach of that patient in a very systematic fashion. But then we need to know when it's time for action and when it's time to react, whether that be in your hospital and your setting, or whether that's, contacting us or your local neurologist to determine when transfer for imaging and a neurologist rather intervention is appropriate. Few last comments as we wrap up and move on into questions. I hope that was helpful for everyone. Please ask your questions. I know we've used up our whole hour, but I'm glad to stay for a bit of questions here, and then the ones we don't get to, we'll certainly send you emailed responses for those. If you don't already, follow us on social. We've got kind of pretty strong presence on Facebook, Instagram, and TikTok, where we post, plenty of educational and case-based information that I think, is helpful. Also consider to register for our 5-hour CE conference that we offer every October. This year it's virtual. You get 5 hours of CE on neuro and neuro-associated topics. Likewise, for your continuing education certificate for your participation today, you will receive that within an hour or two by email. If you have any problems, obviously contact us, but wait an hour or two because you should receive that automatically. So I'm going to now move into questions for those of you that are able to stick with us. Feel free, we'll go through questions for a few minutes, and then obviously I will contact those of you whom I'm not able to answer all of the questions, because it looks like there's quite a few, but we'll hit on some of the big ones, and then we'll contact you individually for those that I don't answer the question specifically here at the moment. Someone asked, when you say low dose steroids, do you mean a 0.5 mg per kg? I think it depends on the scenario. In the, let's say, the conservative management thoracolumbar suspected disc dog, in that instance, a 0.5 mg per kg BID for maybe 3 or 4 days, and then starting, once a day and every other day would be very reasonable. Generally, when I say anti-inflammatory doses, I'm referring to about 1 mg per kg per day, but I will often split that as a 0.5 mg per kg BID, and often for about 3 or 4 days, and then once a day for 3 or 4 days, and every other day for 3 or 4 days. So good question. Let's see. Likewise, on the steroid-related theme, we've got kind of, if I could clarify a little bit more about my preference for steroids versus NSAIDs in a GP setting, if the patient's not going to be referred. Often my preference is going to be for a steroid, as long as, and these are two very important kind of points here, as long as the patient is systemically healthy. So ideally we're checking blood work first. If there's no systemic, contraindications, and as long as we're using it at a conservative anti-inflammatory dose, then my preference is a steroid for most neurologic issues. Again, for things like head trauma, steroids are not indicated. Obviously, pain medications, things like Buprenex and whatnot, are certainly good choices to manage the discomfort. But if we're talking about spinal cases that we're not referring, steroids are the preference, but make sure there's no contraindications systemically. Make sure we're talking about an oral, low anti-inflammatory tapering dose. And also be sure the owner is committed to not coming for diagnostics. So if they're going to change their mind a few hours later, I'd rather the dog have not received steroids. How frequently to give benzodiazepines for status epilepticus? So I presume the question is sort of, you got a patient in front of you that's in status, it's actively having a seizure. How long do we wait between giving those doses? Benzodiazepines like midazolam and diazepam are very fast acting, unlike phenobarbital, which is much more intermediate to longer acting. So those benzodiazepines, often if they're going to work, you're going to see that response, within 30 seconds. So I often don't wait very long before I start repeating the dose. Just ensure that, the movements that you're seeing are thought to still be continued seizures. Some dogs will kind of tremble or fasciculate a little bit post-ictally, so try to make a differentiation there. But if you believe they're still actively seizuring after about 30 seconds, I'm generally working on drawing up that second dose. CRIs of benzos prior to starting propofol CRI, absolutely. So I do CRIs of midazolam probably every day. I do a propofol CRI maybe once a year. So tremendous preference for using CRIs of midazolam over propofol. The instances where a CRI of midazolam is helpful is if your initial boluses stopped the seizure, then a midazolam CRI is going to be your response if that seizure starts up quickly. Or if that patient has already come to you where it's had 3 or 4 seizures that day, it's coming in having a seizure, you give a benzodiazepine dose, the seizure stops. Yes, you'll want to get that patient on a midazolam CRI, and that's the strong preference. The propofol CRI comment is a last resort. Like I said, I think I probably do it once a year. It almost never is necessary, but that would be for the patient who's non-responsive to benzos. So you've given at least 3 doses of a benzodiazepine, the seizure hasn't stopped. You've given Keppra, phenobarbital, you're kind of running out of things that you have available IV to you, then that's where propofol may have a place. If you can stop the seizure though with a benzodiazepine, then there's a reasonably good chance that the benzodiazepine CRI is going to be effective, in which case propofol is not preferred. It's a very good question. Thank you for having me clarify that. We've got, how relevant is the cutaneous trunci reflex in order to identify the specific location of the spine affected? So good question. Even without that reflex, you should have already narrowed down what spinal cord region you think the problem is, meaning the cutaneous trunci reflex is most helpful if it's a T3-L3 spinal cord problem. So the purpose of that reflex would be to see if you can narrow down even more specific than T3-L3. Now, T3-L3 can be, more than half of the length of your patient. So If we're looking to narrow down a little bit, is it more right at the thoracolumbar junction versus somewhere else? The cutaneous trunk eye reflex is sometimes helpful in making that distinction. But you should have already narrowed it down to T3, L3 without that information. And the cutaneous trunk eye reflex is not always particularly reliable. So if you thought it was T3, L3, based on the preponderance of the rest of the evidence of your exam, don't let the cutaneous trunk eye change your mind. Can we give diazepam rectally if we don't have IV access? The answer is yes. If you have midazolam, giving midazolam intranasal has a little bit of a higher chance of efficacy. Intranasal midazolam works almost as well as IV benzodiazepines, so I much prefer intranasal. But if that's not an option, you can try rectal diazepam. It may or may not work, but it's certainly worth a try. It won't hurt anything. But if you've got midazolam, I would give intranasal midazolam instead, if you don't have IV access, or at least until you can get IV access. How quickly should a grade 4 or grade 5 slipped disc suspect be operated upon? So remember, grade 4 are the paraplegic dogs. They've got no motor. And grade 5 means they have no motor and no feeling. So those are our two most affected categories. Those patients should have surgery immediately. So as fast as they can get to someone who's able to image and do surgery, the sooner the better. That same day, we definitely want that to occur within 24 hours if we can help it, but sooner than that is even better. Particularly the dogs in grade 5, they really have the clock ticking on them in terms of the dogs who can't feel their limbs. The prognosis drops from 50 to 5% outside of those first 24 to 36 hours. So certainly as soon as possible, but even in grade 4, we don't want to take the risk of them progressing into grade 5, which many of them will do without intervention. So within 24 hours in a perfect world. Let's see. Someone said they were under the impression that midazolam can't be given rectally. However, they know a few veterinarians who do. So it's not that it's contraindicated. It's just midazolam is going to, because of the lipid solubility coefficient differences between midazolam and diazepam, sort of their rates of absorption are just going to be a little different in different environments. So midazolam is going to be more effective intranasal, whereas diazepam is going to be more effective rectally. It doesn't mean you can't swap those, just the efficacy might be reduced. So if you do have midazolam, I would err on the side of putting it in the nose until you have IV access, but it's not that you're doing anything wrong by giving it per rectum, it just may not work. Likewise, similar question, what dose do I prefer for midazolam CRI? For me, it depends a little bit on how refractory they were initially. So if they come in actively in status epilepticus, and I give a 0.25 mg per kg dose, and it immediately stops the seizure, then I'll start on that dose initially. So they'll go on 0.25 mg per kg per hour. Whereas if I had to repeat that dose 2 or 3 times, then I'm going to start much higher because they seem to be much more refractory. And then I might start at 0.5 or even 0.75 mg per kg per hour. Excuse me. I'll usually stay at the initial dose for at least 12 hours before weaning it over the subsequent 12 hours. We've got a question of in head trauma. Which one is worse, low blood pressure or high blood pressure? Ideally, neither. We want them to be normotensive, realizing that's not always obtainable. If the blood pressure is high, my concern would be, what is their heart rate? If their blood pressure is high and their heart rate is low, I'd be very worried for their intracranial pressure. Are they experiencing that Cushing's reflex that we talked about? So that would be obviously of tremendous concern. If their blood pressure is low, we worry about how it's affecting their cerebral perfusion pressure. And obviously, that's going to result in even greater potential for ischemic damage within the brain. So ideally, we want them to be normotensive. If we can, work very hard to achieve, something relatively near normal, that's preferred. If it's high, we need to try to figure out why it's high. Is it high because we have increased intracranial pressure, or is it high because we're painful? And then addressing, which of those we're dealing with. The last question, because I know we're out of time, and then I'll respond to the rest of you privately, is do I have a personal preference between mannitol and hypertonic saline? I know I went through that slide a little bit quickly as we were running out of time, but I don't have a strong preference. I might have a bit of a preference overall for mannitol in the average of situations. However, I'm very open to trying both, meaning if I give mannitol, which is going to be the first one I grab in most scenarios, and I don't get the response that I expect, but I'm quite confident that they have increased intracranial pressure, instead of redosing the mannitol, I'll sometimes switch and try hypertonic. There are some dogs that seem to respond better to one over the other. The times where I do have a stronger preference is in dogs who are otherwise need vascular expansion. So if they, are thought to be, dehydrated, hypertonic saline might have an advantage in trying to kind of volume restore them at the same time. Also, there's certainly debate about this. It's not a black and white thing, but there is some preference in traumatic brain injuries to use hypertonic over mannitol. So I do tend in primary traumatic brain injuries to utilize more hypertonic than mannitol, but it's certainly not an absolute contraindication. If you only had one or the other and you thought your patient had increased intracranial pressure, I would use what you have in any of those circumstances, but those would be the subtle nuances where there might be a small preference. So I know we're out of time. I apologize if I haven't answered every question, but for the other 10 or so questions that I didn't get to, I will send you a private email attempting to answer your question. I hope that you found this helpful. Again, follow us on social so you can know when we're having other, free CE events like this. And also, like I said, feel free to join us for the 7 Synapse conference that we offer each October. If you have any other questions, feel free to let us know, send us an email. I'm certainly glad to reach out. Otherwise, thank you for coming. I hope you got something out of it, and we hope to see you soon.